defer to Diane, who normally would do a roll call at this stage, and then I'll just confirm with Vicky that we are quorate. So Diane.
Sorry, before Diane starts, Chair, could I ask you to read out the statement regarding the live streaming?
Yeah, I'll do that as part of my comments. Thanks, Vicky. Diane.
We have the following apologies for absence. We have apologies from Councillor Robert Moran, with Councillor Brennan substituting, and apologies from Stevie McLachlan and Dr MacDonald. Chair will now move to a roll call before asking for declarations of interest. Can the following members please indicate if they're present at the meeting? Councillor Brennan.
Present at the meeting.
Alan Cowan.
Present.
Councillor McCluskey.
Present.
Councillor Quinn.
Present.
Councillor Reynolds.
Present.
Anne Cameron Burns. David Gould.
Here.
Dr. Rebecca Metcalf.
Present.
Kate Rocks.
Present.
Jonathan Hines.
Present.
Craig Given.
Present.
Laura Moore.
Present.
Dr. Chris Jones.
Present.
Gemma Erdley. Diana McCrone.
Present.
Charlene Elliott. Margaret Tate. Yeah, I can see Margaret. Christina Boyd.
Present.
Are there any declarations of interest?
Just my usual one about being on the Secretary of the Board of the Carer Centre.
Okay, thanks everybody. Thank you, Diane. I just want to confirm with Vicky that we're quorate. I think we are, Vicky.
Yes, you're quorate.
Thanks very much. And if Vicky will just indulge me, I will of course cover the standard paragraph in a second. First of all, welcome to the Inverclyde IJB. Particularly welcome to Councillor Brennan, who's deputising for Robert Moran today, and also to Jackie Kerr, who's kindly joining us for item 6. So I'm Alan Cowan, I'm the Vice Chair. I'm delighted to pick this up for Robert Moran today. Welcome to any members of the public and also the media who may be joining us. Just to remind them that you join us as observers today, and of course we can't therefore take questions in this forum, but there are other mechanisms for you to engage with us. So please don't use the raised hand or the chat function. As Vicky has rightly pointed out, I've just got a standard statement I'd like to read. This meeting is being held remotely and will be filmed and recorded for live and subsequent broadcast available through the Council's website. The IJB is a joint data controller with Inverclyde Council and the NHS Greater Glasgow and Clyde under the General Data Protection Regulations and the Data Protection Act. This meeting was broadcast and recorded to fulfil our public task obligation to enable members of the public to observe the democratic process. Members of the IJB are reminded that they should follow the IJB's established meeting protocol, which I know Vicky has circulated earlier, so thank you for that, and including around the use of the chat facility, and the comments made in the chat facility are visible to all participants in the meeting, which may include members of the public who've also received invites to the meeting. So with that, thanks to officers for preparing the agenda and producing the papers, and for submitting themselves to taking questions today. As always, I will assume that we have all read the papers and are generally familiar with the content. I'll ask each of the sponsors of the papers to introduce the topic. There's no need to go through the paper line by line or anything like that. Maybe just a brief summary of the salient points and then point to the recommendations that you're asking the board to consider. And at that point, as always, I'll then move to members' questions. With your help today, it's not an overly complicated agenda. It doesn't look like to me anyway. So I'm aiming for a sort of 4 o'clock finish. If I think we can get there, and if you've no objections, we'll move through without a break. If it gets to 3:15 and it looks like we're going to be beyond 4, of course, I'll offer you the opportunity to stop for a short break. But aiming to try and move the business in the next couple of hours. So with that in mind, if you're happy, please, as always, allow me to move us on when it seems appropriate that we need to do so. I'm keen that we don't rehearse questions that we've had previously or go around in circles. So when it seems appropriate, I'll suggest to the board that that we move on. So with that, can we move to item 1? Because I'm standing in for the chair, I can see we've already covered item 1, which was the declaration of interest and the apologies and the substitutions. So for the record, Diane, I'm happy to move item 1. You've captured those apologies and substitutions, and you've raised the declaration of interest, and we note Christina's standing declaration. So let's move then quickly to item 2, which is the minute of the last meeting, which is on the 14th of November. So I'd like to break this into 2 parts. I normally ask, are there any issues of fact, accuracy, clarity or omission? So I'll pause for that. If there are any issues that members have of fact, accuracy, clarity or omission, and then I'll move on to matters arising. Members, any issues of fact, accuracy, clarity or omission? I'm not seeing any hands. Let's have a look. No. So I'm happy to note that members are generally content with that minute. Are there any matters arising from the minute of the 14th of November that you wish to note or to discuss at this point? Again, I'll just pause to see if there are any hands. I'm not seeing hands. I've got a couple myself if there are no hands, which I jotted down. I think for the benefit of the minute, I note in minute 80 that we have had a discussion about the Kincaid strategy process, I think you probably call that, where we were trying to support folks discharging from hospital. And I note that at minute 8, it says our report's coming back in April. We don't have a board in April. So I think for the benefit of the minute, and I'll just ask Kate to nod for this, the benefit of the minute that report, if it's coming back, would come back in the May IGB. We don't have a report. We don't have an IGB in April for minute 80. So subject to Chief Officer's comment, I would suggest that we just minute that report would go onto the rolling action list for May. I'll just pause to see if Kate's content with that.
Yeah, and just if we could call it Kincare.
Yeah.
I think that's a typo. Thank you.
What did I say?
Kincaid.
Oh, I do apologise.
No, it's fine.
Kincare, absolutely right. Thank you for that. So that's fine. The other matter arising that I would note is that minute 84, I can see that the board was, that officers had suggested that they bring back a report on the outcome of the joint inspection of the adult services. That's at minute 84. Provide a future report update following the publication of the inspection report. And I know in Kate's later Chief Officer report, she talks about the inspection report coming in March. So I think it might be helpful if we add that joint inspection of adult services to our rolling action list for, again, I think probably, I'm guessing May. So an update on that would come to the May IGB. That would actually tidy that one up. So again, I'll just ask if Kate's content with that. Kate.
Yes, that makes sense. Thank you.
Thanks very much. So again, subject to any other comments, I'm not seeing hands, so we're content to approve the minute of the 14th of November. Thanks, board members. So that moves us on nicely to item 3. Before I move on, I just want to pause again for a second. There was some suggestion that that Jackie Kerr's item that she's come to speak to, which is item 6, could be advanced by 1 to allow her to go. That would mean that, that the Chief Social Works Officer would drop down 1. Can I just ask Kate if she's content with that, and we'll shuffle those around before I move on. That'll allow Jackie to go when she's finished.
Yeah, I think we'd want to be supportive of Jackie. She's given up time. Thank
Sure.
you.
So okay. So for the benefit members, we will take item 6 out of turn. We'll just move up 1 and drop 1 down. And we're thanking Jonathan for being patient with that. Okay, let's move on to item 3, which is our standing financial report. It relates to the period to the end of October, so it is 3 months old. Yeah, it's already 3 months old. So I'm going to move straight to Craig to provide that report. Craig.
Okay, thank you very much, Alan. I wasn't going to go into a lot of detail because I know we've covered a lot of the finances in the last week or so, especially with the recent meeting we had last week around the budget. But just a high level position at period 7, we are currently projecting an overspend of £865,000 at this particular moment in time. That's split 451,000 in social care, i.e. the council side, and 414,000 on the health side. Moving on to what the main kind of issues there are, first of all, on the health side, currently projecting a £1.6 million overspend in overall mental health adults and then the older adult inpatients and community services. This has been something which has obviously been on our agenda for a while now, and it's quite a historical issue. We also have a projected £1.2 million overspend in the prescribing budget, and at this point we have used 500,000 worth of smoothing reserves towards this position. I'm just going to briefly talk about that at the end. But this is partially offset by underspends in the adult community services, children's community services, management admin, and alcohol and drugs recovery services. On the social care side, we have our main area is a £3.2 million overspend in the children and families area, and this is mainly due to children placements we've had for a number of years. At presently, we're using about £0.3 million of our smoothing reserve to help with this position, and things being the way we're likely to obviously use that going forward. We do know, and as I've said a few times now, there's a particular large piece of work going on at the moment in Jonathan's area about bringing some of these particular pressures down in the coming years. This is partially offset by £2.2 million worth of underspend in the older person's budget, and mainly due to vacancies and reduced costs in both the internal and external care at home budgets. We also have a number of vacancies in alcohol and drug services, learning disabilities, and these are partially offset in this position. Looking at our overall reserves position, we started the year at 24.262 million, and the latest forecast is we're in line at this moment to finish the year with about 14.671 million pounds. Obviously, there's a number of issues in there, most of them we've already discussed in length. To bring it a wee bit more up to speed and up to date, obviously we're working on the period 9 figures as we speak at the moment. So the main one that we're seeing is a bit of a reduction in the pharmacy spend at the moment, but we're just keeping an eye on that to see how that goes. As you know, what we've done is we have used, in this report, we've used £500,000 of our smoothing reserve to that. If anything were to change at this particular moment in time, is that the use of that smoothing reserve is probably going to maybe not be needed as much. So that would obviously, it doesn't change, I would say, the projection we've got at the moment. It just means we're maybe not use as much of the reserves as we're going to need. Obviously, that's the position we've got at the moment. And when it comes to year end, we'll obviously bring that to a break-even position, but that'll be brought by using particular smoothing reserves that we've got. So I think that's probably the main items that I can think that we're dealing with at the moment. But as always, happy to take any questions you might have.
So thanks, Craig, and I guess a reassuring tone around how we approach the end of the year, and also helpful to get the sense that our pharmacy spend is either levelling or it's certainly becoming less than it was in the past. So that's a helpful sign. Of course, it doesn't mask the fact that you've highlighted a few significant overspends masked by some other significant underspends, which is why we get towards balance. So with that in mind, I'll open it to members' questions. If there are any questions, I just ask you to raise your hand, or if you must put something in the chat column, but preferably a raised hand. Question, Diana McCrone. Diana.
Hi, it's a question about the earmarked reserves. Last year, a lot of the money that we hadn't spent got clawed back, and I'm aware that there's still money that's not spent, and I'm wondering, do we think it's going to get clawed back again this year?
Okay, I'm happy to come in on that. It was only a few particular areas where we actually lost money. As I say, I appreciate totally the big one was probably COVID, which is probably the big one. In terms of this year, I'm not aware of anything at the moment about wanting to claw any of that money back. I've certainly not had any conversations of any directions from anybody around that particular area at the moment.
Any other members' questions? I'm not seeing any hands at this stage.
Yes, it's me.
Oh, sorry, Christina, thank you. Go ahead.
I think she must be a mind reader. I was going to ask exactly the same thing about the money that was being carried over, the ring fence money from the Scottish Government, specifically, as we know, because they have forum on this and they took back the COVID money. I know we will spend as much as we possibly can. The other thing I just wanted to ask about was on page 29. We're carrying forward, where is it? 1.154 is on the carers money that's being carried forward. Have we any idea what that's likely to be spent on?
Certainly, I know it's been looked at. I don't know, Alan Best or even Kate, if you want to come in, because I know there was discussions around the use of that money.
So that money would be part of our review around our carer strategy. So as we know that we've put out an independent consultation about what the shape of respite and carer support should look like moving forward. Alan, I don't know if you've got anything to add to that.
Kate, just correct what you're saying there. We're currently carrying out an independent review, and I know that's part of the Chief Officer's report. And once that review concludes, we're consulted with the key partners. That will give us an option about where we take forward support for carers and respite and the sort of portfolio support that we want to develop for the future.
Yeah, I mean, thanks. I'm just slightly surprised that a consultation would cost anything like that amount of money. But I'll look forward to it finishing and finding out what we're doing with any money that's left over.
Thanks, Christina. Can I just ask Alan or Kate just to confirm what's in the comments box, that money, it's clearly says any unused funds will be used specifically for carers. It might just be helpful to reassert that. I know it's in the notes. Is that still our position? Kate.
So I'm not clear about that comment. Is there an impression that we're using that money to do the consultation? Or because that would be part of the funding that would be in its totality about how we support carers. So I've kind of maybe misunderstood that question, Chair.
I think what Christine is looking for is a sense of what the carry forward money might be used for. And as I'm just looking at the comments column, and it seems to be clear from officers that the commitment is made that money has been set aside to be used, unused funds to be held specifically for carers. That's a broad description. I'm just, I guess, looking for an assertion that that's the case. Craig?
Yeah, it's just to say that money will be used for carers. It's not earmarked for anything else in that particular area.
Thanks for that. Christina? You're on mute. You're on mute, Christina.
Right, fixed it. It's right. I appreciate what you said. It's just that in the past we've had a discussion about when money is used for carers, is that actually used for carers or is it used for something else? In the past, Carers Act money was used to pay wages of staff, which you're allowed to do in terms of the Carers Act. I wouldn't suggest that these people didn't merit that money, but it was just that we've had difference of opinion of what is using money for carers benefit. And that was why I was trying to get to the bottom of what precisely it might be used for.
Okay, that's great. Thanks.
You might not know that at this time.
Thanks, Christina. That point is well made, and Craig has said that the commitment is made that money would be earmarked for carers. If that was to change, it would have to come back to the IGB for discussion. So thank you for that. Any other comments or questions on the finance report? So the sense I'm getting is that Craig's giving us a level of assurance that as we approach the last couple of months of the year, we're looking at somewhere around 0.8 of a million overspend, containable within the resources we've got, which is helpful to know. And also, I'm reading between the lines and the report, a range of other work going on in those areas where we've got significant overspends, in the hope that we can somehow bend that curve in the coming 12 months. That would certainly be the aim, is to try to bring those down. So with that in mind, I'm happy to, looking to make sure there are no other hands, looking to the board to be content with the recommendations that are at 2.1. So to note and approve the recommendations at 2.1. I'll just pause there for a second. Thank you very much. Thanks, Craig. That moves us on to the rolling action list, item 4. So thank you again for that. And maybe just ask Kate, there's a couple of items on the list that Kate, I and some other members have had sidebar discussions over the last few days. So maybe just ask Kate to quickly walk us through, not every item, but those items where either the issue is ongoing or she feels there's a comment to be made. So I'll just hand it off to Kate. Kate.
So if I could just start around the proposal for the redesign of homelessness services. To take you through that there is still ongoing discussions about not necessarily the model, but the affordability and the financial cost of the model that requires to be undertaken between Inverclyde Council and ourselves. I appreciate that it's delegated to us, but obviously we need to find a model that is actually that we're able to deliver in terms of cost. So I would suggest, because there's so many operational issues, that we're not ready to come back and give you a timeline about the where we are with the redesign, and I would ask that we take it off the rolling action list, because it's an operational issue that we need to take forward with the council. And at the point that we are in a place that we're both clear, both parties are clear about what that model looks like, we would put it back on as an agenda item. I don't think there's much point of us keeping this on when there's a whole load of factors that we haven't properly explored.
Okay, thanks, Kate. I'll let you move through the others and we'll come back to them in turn. Thank you.
Okay, so the update on the vaccination transformation plan programme. I appreciate that the paper was to come to IGB today, but we have had significant capacity issues across the board over this last 3 months. But I understand that Alan Best is going to give you an update about where we are today, and then we can make a decision about what we want to do moving forward. So if I could just hand it over to Alan.
Yeah, please. Thanks, Alan Best. Thank you.
Thanks, Chair. Thanks, Kate. Yes, apologies that the paper didn't come forward. As Kate said, there's been capacity issues within the service, and I apologise to the board about that. In terms of the vaccination programme, out with, as you know, the responsibility for housebound and the care homes vaccination lies with the HSAP, and what we call the ad hoc vaccination and the travel vaccinations lie with NHS Glasgow and Clyde Board. And I know there's been a previous paper to the panels with specific issues around the ad hoc immunisations with people having to travel distances to receive that. We have continued to work with the vaccination meetings within NHS Glasgow and Clyde. On average, there's around about 20 ad hoc requests for Inverclyde per month. I'm glad to say that we now have an agreement where we've got about 20 appointment slots are allocated each month locally within the mass clinic environment locally, with the vaccinations happening locally, which gives us capacity with roughly about 5 appointments a week, which will cover the demand for ad hoc vaccinations. So therefore, having looked at the demand over the last year, we're confident that there's ample needs to meet the number of referrals that are coming from Inverclyde in terms of ad hoc. Where there's potential challenges in this, and where there's peak periods for the mass vaccination clinics, i.e. the height of winter and in the event of any future vaccination programmes such as COVID, we would have to look at that, because obviously the priority would be around those vaccinations. But I am assured by the ad hoc vaccination team, that any urgently requiring an ad hoc vaccination we wouldn't be covered by the housebound team, would receive that vaccination locally. So that gives us an improved position on where we were before. Be happy to take any questions.
Okay, thanks, Alan. I'll hold that again until we complete. So the other one, Kate, I think that might just deserve a comment is the Improving the Cancer Journey, which we were going to bring, I think, but we haven't brought it this time. Maybe just comment on that one as well.
Again, apologies, a capacity issue, but we're also waiting from some data to come back, both from Macmillan Nurses, which we've actually just got recently, and from the board. What we have done, if you can see in my Chief Officer's report, we've made some reference to some of the improvements, particularly the interface around Dying Well. But we will probably come back with a report to you. I would suggest May, realistically, on the basis that March is a really busy agenda item. Okay, thank you.
So thanks to officers for just clearing those up. So there's really 3 issues that were for discussion there. The background to the homelessness report, the vaccination transformation programme, and the report on the cancer journey. If I take them in reverse, because I think we're just trying to tidy these up. I'll open it to the board on the cancer journey stuff. My sense is that's a fair compromise, is bringing that report back in May this year. So if the board members are content, I'd ask them not to raise their hands then at this stage. But we're content with the Chief Officer bringing that cancer report for the reasons she said back in May. That I think would tidy that one up. We're left with the homelessness paper. Chief Officer said that she's got further discussions to have with the council, content about the model, but of course there are funding and other structural issues that she needs to negotiate, and she's suggesting that on that basis, I guess, an element of trust in the board also, that we take that one off the rolling action list, noting that it will come back when those discussions are complete, which sounds like it's not going to be before the summertime. So with that in mind, again, I'll just pause for a second, see if board members have got comments. Otherwise, I think we're content that we could take that one off and accept that that will come back when the discussions with the council are more mature. I will look for hands, of course. It's my reading of the situation, not necessarily everybody's. I'm not seeing any hands. So I think, again, Kate, we're happy with that approach. We'll take homelessness off the rolling action list. We'll simply sit and hope that by late spring, early summer, that we've got a position that you can bring back. If not, you might use your Chief Officer's report just to keep us up to date what discussions look like. So we'll take that one off as well. That leaves the vaccination paper, which again has been there for a while. I know members have got interest in this. Level of assurance by Alan Best that certainly the ad hoc vaccinations, whether to be required, could be done locally. Alan's opened himself to questions. I'll just pause there. If there are any questions or comments by members, look to do that now. Councillor McCluskey Martin.
Thanks, Alan. Thanks for the update, Alan. That sounds very positive. I think just one comment and a question. Just in terms of the comment, it would still be useful to have the data presented in a paper, in my mind, in the same way that we have in the past at some point, if that could be brought forward with the numbers for all the different types of vaccinations as we've had previously. And then just on a point of clarification, does what you described now mean that no one should be asked to go out of area for a vaccination? Certainly based on the numbers that you've described, 5 a week, 20 a month, then we should be able to meet all the demand locally. Is that the case?
Alan.
Yeah, thank you. Yes, I spoke with the vaccination team at the board at lunchtime, and they confirmed on the current demand that we have just now that there's ample room to accommodate that. But obviously, as we would do, we would monitor that locally, and any feedback and an increase in demand, obviously we would go back to the board on that. I think where the issue rises if there's an excessive demand on the mass vaccination clinics and the priorities given to them. That's where that potentially that we would need to again just keep a watchful eye on the situation to make sure that ad hoc vaccinations are being accommodated locally. But I have assurance that in the case of an urgent ad hoc, that no matter what, they would be accommodated within the local clinics if it's an urgent it needed to be delivered fairly quickly. So I think the position is certainly a lot more positive than it was previously, and again we're keeping that dialogue going with the board. Yeah, thanks Alan. Martin.
Yeah, thanks, Alan. That's really helpful. Does that mean then that, apologies, I've got a really bad cough today. The last paper that we received at the last meeting talked about questions around the future sustainability of local vaccinations. Does that mean that we've now had assurance that there are no questions around the sustainability of local vaccinations in future?
At present, the position that I've been informed is that the vaccination clinics in terms of flu, seasonal vaccinations, shingles, pneumococcal vaccinations will still remain locally. Yes, so that would be the position that we have, the information that we have at the moment. And should,
And now the ad hoc, on the basis of what you've said today, they'll also now remain local.
Yeah, the ad hoc, when they've actually scheduled in appointment spaces for them specifically, so that tells me that it's not just a squeeze them in. It's an actual. These are trying to make them available throughout they're based in 10 a.m, 12 p.m, 2 p.m, 4 p.m, 6 p.m throughout the clinical day. So that's become established in their clinical appointment system. So that's specifically for the ad hoc vaccinations.
That's great. And just very final question, if you'll allow me. where will those vaccination centres be? Just because of
it's where they're currently Inverclyde. Oh, yeah.
Sorry, Alan. I think
Thank you very much.
It was all a bit garbled. I'm just going to ask you to repeat that, Alan, best. It was garbled at my end. I think the question was, where were they delivered, Alan?
Kind of connection. I'll put the video off, see if that helps the connection. Currently, that is within the areas where the Greenock Town Hall, where vaccinations are currently being provided, and the ad hoc centres where they're set up for that.
Great. I think Martin's generally assured there on some of those responses. So I'm going to move on to Becky Metcalf. Becky.
Thank you. Sorry, Alan, I just want to lead on from Martin's question there. Does this include travel vaccinations as well? Because obviously that's slightly different than the other ad hoc routine vaccinations that you've mentioned.
Yeah, thank you for that question for yourself, Chair. No, this doesn't include travel vaccinations. The travel still remains a position where the board has had to resume taking on travel vaccinations. You know, it was originally contracted out. I think the argument at the moment there is that there's not a plan to create a second travel location at the moment within the board. I think that the viewpoint is this is something that people opt into in terms of it's a personal choice for travel. So that doesn't include travel vaccinations at the moment.
No, thank you. That's really helpful because that makes more sense then in terms of what's provided. Thank you.
Thank you.
So I'm keen to move on from the rolling action list. I'm looking to see if there are any other comments and hands. I'm not seeing any. So really, subject to the discussion we've had, the fact that we're content for both the homelessness and the cancer journey so the homelessness to come off and just be seen as routine business, Chief Officer brings it back. For the cancer journey paper to come in May, where there's a little bit of space, that's a routine cycle, that'll be helpful. And for the assurance that we've taken around the discussion on the vaccination transformation programme, recognising that it's a complex area where most of these things can be delivered locally, but not all. Some of it's wrapped up in the contractual arrangements, I know. And as Alan has said, some of those are optional things for travel, which we can't do much to change. So with that in mind, I hope we're content with the discussion on the rolling action list. That being the case, I would be keen to move on to item 5, which is now the mental health strategy refresh. That will allow Jackie to play a part today, take some questions and hopefully get back to a normal job. So with that in mind, I'm just going to move to item 5, which is the NHS mental health strategy refresh. I'll just pause and see if Kate wants to say anything before I move straight on to Jackie Kerr, who's kindly joined us from GGC. Kate.
Yeah, so this is just really a presentation to look at the excellent work that we're doing system-wide about the delivery of mental health services. And actually, it takes into consideration some of the local developments that we want to do in Inverclyde, as well as looking at the system-wide pressures that we have, and there are obvious pressures coming out of the pandemic. It is also a substantive bit of evidence that we are submitting to the Care Inspectorate about how we work in that system-wide approach. And for smaller partnerships, particularly Inverclyde, how that gives us a level of capacity that we wouldn't have had if we hadn't been part of that wider or larger partnership approach. So with that in mind, I just want to pass it over to Jackie, who's been the lead for this work. Thank you.
Yeah, thanks, Jackie. Thanks, Kate. So Jackie, please take it away.
Thanks, Chair. Well, hello everybody. My name is Jackie Kerr. I'm Assistant Chief Officer in Glasgow City HSCP and the Chair of the Mental Health Strategy Programme Board. I'll not go through the report in detail because it's a very lengthy report, and obviously there's links for the strategy and the previous strategy. So just really, this report is to update the IGIB on the refresh of the mental health strategy from 23 to 28. Members will remember that we brought a strategy in 2018, which was the first 5-year strategy after we'd done significant work in benchmarking our mental health services across other health boards in Scotland, but also in England. And we made some progress in that strategy, but obviously that stopped during the pandemic. In 2022, the system took stock of where we had got to. the challenges in the system, because we have seen significant and unprecedented challenges in our mental health system really since COVID, and some of the developments that have happened during that time. So the refresh of the strategy includes developing a system of stepped and matched care, allowing people to get the right level of care at the right time, promoting early intervention and prevention, better responses to crisis, avoiding unnecessary admission to hospital and reducing the length of stay, and shifting the balance of care from high-cost inpatient services to local community alternatives. We have widened the scope of the strategy so that it includes all of the mental health family. And as Kate said, we try to make sure that our mental health services are a system-wide approach, and that the strategy includes children, learning disability, alcohol and drug recovery services, and older people services. And it also highlights the progress we have made during the life of the previous strategy. So the strategy is linked into 4 phases. So the current strategy priorities for the strategy in phase 1 are reducing the reliance on inpatient beds and developing local community alternatives, including a community rehabilitation service, an enhanced care home liaison service, an expansion of our evidence-based borderline personality disorder service, the development of community mental health acute care services, not only for adults but for older people, and expansion of dementia post-diagnostic support. So the first priority of this strategy is to go out for a wide consultation on the retraction of the inpatient beds. And over the last few months, we've been working with Healthcare Improvement Scotland to develop a communication and engagement plan. The paper outlines some of the key achievements that have been made during the life of the previous strategy, and I just wanted to highlight these to the board. And these include the expansion of our computerised cognitive behavioural therapy, the development of our mental health assessment units, the development of our community acute care services, the development of distress responses, the development of digital interventions, particularly around psychological therapies, and the development of a workforce plan and the introduction of new roles and skill set. And I'm asking the IJB to note the mental health strategy refresh from 23 to 28, and I'm happy to take any questions.
Jackie, thanks for that summary. Again, I will pause. I'm sure there will be comments or questions. First hand is Diana McCrone. Diana, please go ahead. Then Christina.
Hi, Jackie. I know the trade unions were very concerned about the number of beds that are disappearing, and that there may not be the community resources to look after all the people that would result in being community from that. The strategy doesn't specifically mention the demand that's currently coming from neurodevelopmental disorders. And my understanding is that a lot of community mental health teams have huge waiting lists that comprise a lot of people who don't just have mental illness, but have neurodevelopmental disorders as well. And the strategy doesn't specifically say anything about that.
I'll take the inpatient question first, Kate. Diana, so the retraction of inpatient beds will go to fund community alternatives. So it's not about a cost-saving exercise. We will invest in our inpatient services to make them as optimal as we can, because we want to make sure if people have to come into an inpatient environment, they come in and they're treated effectively and efficiently, and they're able to move out into the community. But it will invest in local community services. You're right about ADHD and the neurodevelopmental disorder. We did have a plan that we were working on developing a centralised team with our autism team. And if you remember, the Scottish Government was giving us money for primary care mental health services. That money didn't transpire because of the financial position of the Scottish Government. We have sent that proposal because what the mental health director are saying to us is that the Minister is keen to do something in terms of ADHD. You're right, there is a significant pressure on community mental health teams. It's not a priority for community mental health teams. We do have a waiting list initiative, but it's not a priority because obviously community mental health teams deal with people with enduring mental illnesses rather than assessments for ADHD. So we've sent the paper to the Scottish Government, Diana, but we've not got a proposal. We have taken options to the chief officers in terms of how we manage this with primary care, and the chief officers are currently considering these options. What we'll do after there is a decision at the board about what option we decide to do or we decide to develop, we'll bring that to the IGIBs for information.
Thanks, Jackie. Diana, just briefly come back to you.
No, thank you for that, Jackie. And I know I see you at the steering group, so the discussions I'm sure will be ongoing. But I was just a bit concerned that the neurodevelopmental demands were not mentioned in the strategy.
Thanks. I've got two questions. Christina Boyd, then I'll move to Councillor McCluskey. Christina.
I mean, yeah, this is an excellent paper, but in general terms, it relies on, first of all, having sufficient finance, which has already been alluded to. In certain areas, you definitely don't have that. And the other area, which is a board-wide, indeed a UK-wide problem, is getting the correct staff to do it. So if we can get the money, which is a big if, and if we can get the staff, then there's a lot of excellent things in here. Now, honestly, I have not been speaking to Diane before this, but the previous issue, we certainly had the same idea as well. In common with her, I mean, I'm concerned particularly where it talks about reducing number of beds for things. I know that it's better for people to be treated in the community, but what has happened in other areas within the NHS is either the community facilities have not materialised, or more commonly, when the community facilities have materialised, they've not been of a sufficient number and a sufficient quality, so that the people who previously were receiving the service felt that that service had in fact been downgraded. And that's been a problem in very, very many areas throughout the NHS. And also, I appreciate you going out to consultation. If some of these bed reductions and various assorted reductions are happening within Inverclyde, that is a specific concern for us, for the people who live in Inverclyde.
Jackie.
Thank you, Christina. A couple of comments. Obviously, the strategy, we thought that we would have some transitional money at the beginning of this in 2018, and that's obviously not the public sector finance position now. So any closure of beds has to be reinvested in the community or in inpatient services to make them having optimal care. If you look at, and we did the benchmarking again in relation to our mental health services. If you look at NHS GG&C's usage of beds, particularly older people's beds, it is significantly higher than any other board in Great Britain. So we need to put in alternatives, and we know that people getting stuck in hospital is not good for people. We know that it would be better if we have community alternatives. It's interesting because we have developed our MBT and DBT services, which are evidence-based approaches for borderline personality disorder. Borderline personality disorder patients in inpatient beds are really challenging for the staff. And actually the evidence of them being treated in the community and people being able to be stabilised in the community is significant. So we need to work on it. We have the bed pressure just now is not in older people's, it's in adult acute. It's not in IPCU either, intensive psychiatric care, it's in adult acute services. So there's a bit of work we've got to do before we can reduce any of the beds. You're right, we would need to come back and look at what the beds are, and we're doing that piece of work just now. We also need to look at the state of the estate. Inverclyde actually has really good estate, in particular in Inverclyde Royal, in terms of the state of the estate. That's not the same across the patch. So we're trying to make best use of the wards that we've got so that we can make sure they are used as efficiently as possible. I think the other bit that you mentioned was about the national shortage of medical and nursing cover in mental health. It is a national shortage. Our Chief Nurse, Lorraine Cribbin, has been working really hard at looking at a workforce plan, particularly for inpatient services. So we have recruited this year 160 NQNs, which are newly qualified nurses that are being placed all throughout mental health services. That's a huge feat. And we're also working with the Open University developing healthcare support workers so that they can move on to get the qualification to become nurses. We are raising with the Scottish Government the national shortage of psychiatrists because it is an issue for us. And you'll know that that's been, Kate has had real challenges about trying to get permanent psychiatric cover. in Inverclyde, and it is a real challenge for us, and we continue to work and raise it with the Scottish Government because it's a national issue. It's nothing that we can do as a board, although we try to do as much as innovation as possible. What I should say, when we have these national and these local challenges, we work as a whole system. So when Inverclyde is struggling, and it has had some challenges over the last few months, we'll redirect staff, particularly from Glasgow City, down to Inverclyde, so we make sure that the system is safe.
Thanks, Jackie. I mean, it's an area of clearly of national importance, and it's really helpful to hear, I guess, to hear local voice, you know, come to the discussion, and hopefully help to inform thinking as we go forward. I've got a few other questions. I'm going to ask Martin to sit in his hands. He would be next. I'm going to go to Charlene and come back to Martin. Charlene.
Thanks, Alan. Hi, Jackie. I'm Charlene Elliott, Chief Executive of CVS Inverclyde. We're the TSI supported the distribution of the mental health, Community Mental Health and Wellbeing Fund monies. I was really pleased to see in the recommendations around the need for continued partnership working, and we do work closely within Inverclyde HSCP on the distribution of those funds. And we've distributed well over £500,000 now into the third sector in Inverclyde, and that's fantastic. And we're seeing some really good impact, but I think what's missing from the fund itself is actually evaluation. We do monitoring, but the funding doesn't stretch to proper evaluation and really understanding the true impact that the fund has on individuals, the communities, and some of the HSCP services as well. So I was pleased to see the approach for continued partnership working to improve that evaluation going forward. So it's just an observation. Thank you.
Thanks, Charlene, and thanks for bringing that third sector, you know, perspective and vocalising what what your thoughts are there. Councillor McCluskey.
Right. Thanks, Alan. Thanks, Jackie, for this paper. I also sit on the health board, so I've also seen this when it came through the health board. And part of my question is really just because situation has developed since then. I'm just wanting to build on the questions that others have asked about funding and the sustainability of the strategy, in particular what it says on page 70 around there would need to be consideration when developing the financial framework to support delivery of the strategy. I was quite surprised in the Scottish budget to see no uplift at all for mental health this year, which, given the the real need that is laid out in your paper, but also all of us probably can see in our own day-to-day lives as well, that there was no increase in mental health funding at all, not even in cash terms. I'm just wondering what impact that has on the delivery of the strategy. And then secondly, on again, slightly building on a question Christine asked around staffing, we're obviously sitting locally with an overspend in mental health, largely because of staffing. And I'm just wondering what the strategy is for reducing reliance on agency nursing, which is obviously a lot more expensive than our own nursing. And is there any plans, aside from what you've already described in workforce, to kind of reduce the reliance on agency, and not just here, but across the area? Thank you.
I would agree, Councillor, there is a real issue that we're going to get no uplift from the Scottish Government in terms of mental health services. We have raised it, we haven't even had our allocation letter for 23-24 for Action 15, which is what some of the third sector funding is from, so that is a real challenge for us. We've raised it with the Directorate. We meet with the Directorate at the Scottish Government every month. They're saying to us that we will get the funding letters out before March, and it'll be 80% of funding that will be allocated, so we're waiting to see what that looks like. We have sent in, because the Minister wanted to see the ADHD work that we have done, because it's a significant piece of work in terms of how we'd have to have a system-wide approach. You're right, every HSCP that has got inpatient services is under significant pressure in terms of the acuity of need that's in the wards and the complexity of need that's in the ward and the staffing that we have for it. 67% of additional staffing, so bank and agency, is on observations. And that's when we need to put additional staff in because of the distress of the patients. We are working, so just to say that we've reduced agency costs by 95%. So we're now into bank costs, which is much better and is much more consistent because they're our staff and they tend to know the patients. But what we're about to roll out this year is a continuous intervention policy. So that's a bit different. So that isn't about putting people to outside somebody's door, but that's about looking at the early triggers of people's distress and working with them. in terms of a proactive approach, so that we don't wait till people are significantly distressed and then they need observations. Observations is not the way to do it anyway. It's about making sure that we can engage with people at the right time. So that will be rolled out. You'll see that being rolled out in 23-24, which will allow us, we're just about to purchase activity boxes across all the wards, and that'll be to try and engage with people, distract them, looking at positive behaviour as opposed to trying to deal with aggression and violence as it occurs. So we have got a policy in place. It's rolled out in England, actually. It's significant in England. We were going to roll it out about 2 years ago, but we've had pressure, obviously, with the pandemic. But that's us ready now to roll out the continuous intervention policy across the board.
Jackie, thank you for covering that. I mean, what I'm sensing is a general consistency. There's three questioners all asking broadly the same issue, and it's actually an issue that comes up for most strategies and plans. It's normally around the funding, the finance and the workforce. And you've given us some sense of the understanding of that, which is helpful. I sense this will be a subject we'll come back. We'll want to come back to at some stage in the future. But thank you for bringing it to attention today. We know that the Health Board approved it back in August, because I too was there. So it's helpful to just hear you today and take some of those questions for members' interest and scrutiny. So with that in mind, I'm just going to look to members and ask, are they happy to note the report today on the new mental health strategy refresh, and note the recommendations at 2.1 and 2.2. Thanks very much to the members. Jackie, thanks for your time. Grateful for that. Thank you very much.
Okay, thank you. Bye-bye.
That moves us nicely on then to, let me get the numbers right. This would be item 6, which is the Chief Social Work Officer's annual report. First of all, let me thank Jonathan for his patience and allowing us to slip in by one position. I know Jonathan's going to talk broadly about the report, the annual report, and I understand there are a few slides and things to support that. So I'll just hand straight on to Jonathan. Jonathan.
Thank you, Chair, and apologies in advance if my connection is weak. I have dialed in as well as a backup, so I may need to swap over devices, but hopefully members can hear me okay. Thank you to Diane as well for assisting with the slides. This is a very brief presentation, really to try and capture the key points of the annual Chief Social Work Officer report for 22 to 23. It does follow a slightly different format to previous years and reflects learning to inform a national template, which was adjusted through the course of the pandemic to reflect the changes in impact on Chief Social Work Officer workloads. Members will be familiar with the Chief Social Work Officer role from previous years, and it's a crucial part of governance arrangements in terms of professional practice and standards, as well as some specific decision-making and delegated arrangements. In terms of local governance and what this means, in my capacity, I attend the Public Protection Chief Officer Group for professional advice, also the IJB and the Social Work and Social Care Scrutiny Panel, which certainly offers a fairly unique additional layer of scrutiny and oversight of activity throughout the year. In terms of the next slide, this really summarises the key points from the full report itself. Where the report seeks to highlight the impact of social work and social care services across our communities to enable people to feel safer, included and more supported. And it also makes reference to national policy changes and local demand, as well as future challenges for local social work provision and national delivery. Members will be familiar with services having continued to deliver and continue to adapt to changes according to variations in demand and complexity over the past year. And indeed, that's a theme talking to other Chief Social Work Officer colleagues, that it's recognised nationally that the role is complex and has various responsibilities, and local variations reflect some of those developments, particularly where the role has developed as a standalone post in some partnership areas, but others like Inverclyde have blended it with an operational head of service responsibility as well. The next slide captures the main points from the basis of report, which I have to thank my head of service colleagues across the SNT for having provided information on their areas of responsibility within the report as part of the papers today. And overall, the report considers the impact of those services on outcomes for citizens, which continue to guide our more broad strategic service planning. The report also considers governance and accountability, service quality and performance, as well as the impact on resources, workforce matters, and looking ahead to anticipate future needs and priorities, particularly given the continuing pressure on financial provision for services for the most vulnerable people in our local communities. For ITB members' information, the report has already been presented to Inverclyde Council following the due process in terms of the accountability arrangements, where the report was approved for onward submission to the Office of the Chief Social Work Advisor to the Scottish Government. The next slide, however, captures some of the key messages that really reflect the work of social work and social care teams across Inverclyde in the previous year. And it's fair to say that a recurring theme across services and care groups has been the impact of coming through the pandemic, right up to addressing the current cost of living crisis. And the report includes highlights around efforts to mitigate that, including broadening ways that people were able to access financial support in Inverclyde over the past year. The report also highlights a number of areas where services have worked with established partners, and we know in Inverclyde that our cross-sectoral relationships, particularly with the third and independent sector, are critical to the primary role of social work, which is to protect people from harm in accordance with statutory duties. So the report includes information on that point, particularly around child and adult protection and the management of high-risk offenders, as well as prison and community-based justice social work services and other statutory measures to protect people, including our mental health officer activity around guardianship, etc. Another underpinning principle was improving how the voices and experiences of people who use services can influence them in their design and delivery. And there is content particularly around the work of the I Promise board, young people, and across care groups, the importance of advocacy and quality conversations with service users. The experience and views of our workforce and support to staff groups is another fundamental part of the Chief Social Work Officer role. So that's reflected in detail around workforce wellbeing, the workforce plan, and considering some of our recruitment and retention challenges, as well as the need to continue to be innovative and to support and develop the social work and social care workforce. In terms of the key achievements, and I appreciate that this report is in retrospect, so a number of these key achievements on the next slide will be familiar to people from previous reports, but the report does consider developments such as the Family Wellbeing Service and family group decision making, which was a test of change around early help to build family capacity and reduce the need for children to become involved in formal processes. And that links with our participation as part of the North Strathclyde partnership in the Scottish Child Interview Model and the Bairns House with other local authorities, police and Children First to reduce the impact on children of the need to provide evidence to a standard of evidence in chief through formal court proceedings. We also uplifted the fostering fees, and there was a commitment to do so in Inverclyde locally before the national uplift was since announced. Alongside that, in terms of supports to young people, we developed our 7-day through care support service, which recognised that young people in times of need didn't just require social work and social care support during office hours. So we've expanded that across the 7-day model and developed the skill mix within that team as well. For adult services, we built on our MHO team capacity and added to that particular team, as well as improving the triage of assessments following a service review. And the integrated nature of our partnership is well reflected in the social work and social care task as well, particularly around the joint working across mental health, addictions and justice services, where we developed a more triangulated approach to supports in recognition of the overlap of people coming in and out of those services in particular. And that was supported by further developments around the launch of the bail supervision service as an alternative to remand at Greenock Sheriff Court. I mentioned the creative approaches to recruitment before, and again, some of the developments around targeting master's students and supporting our newly qualified social workers through that supported first year, and the work of our training board have been fundamental to those achievements. The next slide, however, does capture some of the key challenges which will be familiar to us all, particularly the impact of the cost of living and how we were able to expand greater access to Section 12 and Section 22 payments to try and mitigate the impact of that. The drug-related and alcohol-related death statistics in Inverclyde continue to be a challenge across the partnership and beyond. And although we've seen a reduction nationally, Inverclyde continues to see a significant comparative rate of drug-related deaths, which continue to challenge services. And that reflects some of the commitment and the focus across the partnership, but particularly within my role around vulnerability and risk. And we are looking to align our Child Protection Committee subgroups as one example around areas of particular risk that also reflect more recent developments in national child protection guidance. Shifting the balance of care is a challenge across all care groups, and that's really in recognition of shifts in demand and the pressures within our financial landscape, particularly for children and family services looking as part of the future redesign to reduce the number of children in external residential placements and grow our local fostering community. And I suppose also within that, we will be shaped by those national policy developments, particularly the National Care Service and the National Social Work Agency as well. So that brings us to the final slide, really trying to capture the key points that we want to look ahead for as part of the integrated arrangements in Inverclyde. And that development of the National Care Service continues to be quite a significant whole system change and continues to evolve and develop. And we will play our part, as we have over the past year, in ensuring the voice of Inverclyde helps to inform the shape of that service.
I think we might have lost Jonathan there. Are you still there, Jonathan? No, I think we'll assume that he'd come broadly to the end of his presentation.
Yeah, he's on mute.
He's on mute. Okay. Maybe he can hear us. Jonathan, you've gone on to mute. I don't know if you want to.
Can you hear me now?
Let me intervene. Is Jonathan there?
Alan, I believe I'm back on a different site, so I hope you can hear me. Wonderful.
No worries, I can hear you. I think you were just finishing up. Thank you.
So the very last slide, as I say, just captures the focus around those national models for delivery, as well as our ongoing work to recruit, but also to retain our experienced workforce. And looking as well at those interventions for service developments to help improve impact and outcomes for children and young people and adult services as well, really looking at those evidence-based programmes. So finally, in conclusion, I would just like to take the opportunity to pay tribute to the entire social work and social care workforce in Inverclyde, who along with their health colleagues continue to be our greatest asset, and certainly the successes of the past year are theirs. But I hope that that brief presentation on the key points of the annual report does assist members to understand the work that's undertaken, but also the focus for the year ahead. Thank you, Chair.
Jonathan, thanks for that. First of all, thanks, Jonathan, for providing that short report to bring the report to life and to highlight the things that you feel are important for the board to grasp. On behalf of the board members, thank you for that short presentation. It's been really helpful. It's a critically important report. We note that. We note that Inverclyde Council has had the opportunity to view it, to scrutinise it, to ask questions, and is broadly content. We also note that it's going to go to the Chief Social Work Advisor in due course. I think the report does well in highlighting what the breadth and the scope of the Chief Social Work Officer role is. I'm often reminded by Kate and sometimes Jonathan about that. I think sometimes we don't really recognise quite the breadth and the scope of that. I think it also is good at the report is good at highlighting both really the demand in local services for social work and social care. So I think it achieves that. I think that last point, vitally important. We've heard it before, that the size and the shape of the workforce is critical in developing the care and the services that we need. We always seem to come back to that. I've got a question, and then I'll move to members' questions. My question, Jonathan, is really about the scheme that we crafted to help entice our social workers to come and work in Inverclyde. We set aside a fair sum of money to help them with their master's final year, I think, and part of that was that they would then come and work in Inverclyde. I wonder if you might just give us a little bit more about that how you think that is progressing and whether we've actually got anybody in the system, or how we're progressing that scheme, and then I'll open it to members' questions. So it's really about the recruiting new social workers.
Thank you, Alan. Yes, it did generate some local success for us. We were able to engage 3 applicants out of a number of 6 who are with us as part of that process, but we also did manage to recruit other qualifying social workers to take part in that incentive scheme. So it helped publicise and promote Inverclyde as an employer of choice, but certainly it did generate some direct benefit in terms of recruiting a small number of staff, and it's something that we are looking to revisit over the next year as well.
Jonathan. I mean, maybe just a challenge to Kate. I wonder if, as we get into next year, if there are any positive developments in this space, if Kate might weave those into her Chief Officer report as and when that would become available, just so we can get a sense of what we're getting for this money that we've set aside in terms of recruitment. But thank you for that update, Jonathan. Let me move to members' questions. Questions from members. That was a fairly comprehensive run through by Jonathan, and the slides have supported that. I see Councillor McCluskey. Martin, please go ahead.
Thanks, Alan, and thanks, Jonathan. This was a really interesting paper to read. I want to focus just specifically on the sections on fostering and adoption, just because there were a couple of things that I just wanted to ask off the back of that. Firstly, our fostering fees in Inverclyde, I noticed that there's been a 25% uplift. How do we compare to other parts of Scotland at this point in time? Are we about average, or are we below? That's just first question. And the second question and final one, just on adoption. I was really struck and interested in the fact that we have more approved adopters than the number of children seeking adoptive families. And I'm wondering if is that the norm? Is that what other authorities would find? And this may be a very naive question, and you're probably going to tell me why we can't do this, but is there any way of converting any of those individuals who might want to adopt to encourage them to look at fostering, or is that just quite a difficult ask of people? And if they, is that a decision that people largely make? It's one or the other. Thanks very much.
Jonathan's still there.
Thank you, Councillor McCluskey. Very briefly, since the decision by Inverclyde to increase the fostering allowance by 25%, the Scottish Recommended Allowance has now been implemented across the country. So in some ways where we sought locally to address and bring a level of equivalence to the foster care rate, work on the national approach to that to avoid that local variation has come into place. So I suppose to answer your question, we are now on an equal footing with other partnership areas where we've brought that national recommended allowance into being. In terms of our figures for people approved for adoption, the permanence journey that children take will change from year to year. So one year we may have a small number of children who are considered to be suitable for adoption in terms of their best interests and their best outcomes. Other years it could be a smaller number, and sometimes that can also be affected by specific circumstances such as sibling groups who may also be looking for adoptive families. We have a number of foster carers who will be approved to be foster carers pending an adoptive placement. So depending on the legal route, we may have some adopters who will be dual registered. So they'll be registered as foster carers for a child or children, pending the legal process would allow them to then become the adoptive parents of that child. So the numbers will vary back and forth, but ultimately the numbers that we're looking at are always about the number of children going through permanence processes as opposed to the number of foster carers. We have 26 fostering households, just for some context, in Inverclyde currently, and it certainly would be our hope through our development of and redesign of children's services to grow that number further.
Thanks, Jonathan. A fairly comprehensive response to Martin's 2 questions. I'm fairly sure Martin's content with that. I'm going to go to Kate. I feel it might be something to do with that. It was Becky next. I'll come back to Becky. Kate.
I suppose just to add to Jonathan's point is that we are also looking at our adoption support, Martin, because what we are in essence is assessing for other local authorities to place in Inverclyde. And because of the demographic size and intergenerational challenges sometimes we have, you know, we need to make sure that any subsequent permanent placement for a child is not compromised by that. So that will be part of the redesign. And so your point is well made about the focus on the fostering more than the adoption. So just to kind of reassure you that too.
Thanks, Kate. Let's move on to Becky. Becky, thank you.
Thank you. Yeah, Jonathan, just once again, thank you so much for this report. It's a really interesting read. Thank you. I wanted to ask two things, just that my area of interest. First of all was about the supporting young people in the through care, and I know that there was 158 young people eligible and 99 were actively supported, and I was just interested in the 59 that weren't actively supported, and was that because they had other area support or they opted out, or is that a capacity within the through care service? And the second point, which you've already highlighted as being a particular area of challenge, was the increase in drug deaths, and obviously Inverclyde is particularly challenged in that area, and I appreciate it's a really complex area, but I just wonder if you could give us an update in terms of that service. And I know we'll be probably getting an update on the MAT standards in a couple of months' time, but just any challenges that service are facing or things that they're doing to try and tackle that. Thank you.
Thanks, Becky.
Thank you very much, Becky, and thank you, Chair. Through you, to go to your first, Becky, about the uptake of through care. Through care support for young people is something that young people choose to engage in. So it's really encouraging, actually, that we've got such a high uptake. 99 of 158 is, by comparison with other areas, really strong. And I think that's testament to the team in terms of forging those relationships with young people over the years. And as young people move towards greater independence and adulthood, sometimes they feel well supported in their own lives, and feel that sometimes they also just want to make a move away from the structures of support that they've been familiar with in childhood. But for the young people who don't actively engage in through care, we continue to maintain contact with them so that they know the services there. And sometimes they'll come back and forth, they'll engage and then go it alone for a while, and then they'll come back, but the service is available to them, and we do continue to keep in touch so that they're aware of the supports that we can offer them, depending on their own personal circumstances. The issue about drug deaths, as you rightly point out, continues to be a real challenge for Inverclyde, and I suppose given the fact that we've got Gil Kilbane, our interim head of service for addiction services, it might be an opportune time, if the chair's in agreement, to bring Gil in to talk about some of the work around drug deaths. I would imagine Gil or Kate might be well placed to give a wee bit more detail around the non-social work aspects of that, if that would be helpful, Chair.
Thanks, Jonathan. If Gail's there, maybe ask her to say a few words and come back to Kate.
Thank you, Chair. Yes, obviously, you know that we've implemented MAT standards 1 to 5, and that's live. The challenge this year is to implement MAT 6 to 10. Most of the drug deaths that we have in Inverclyde, most of the people are not known to Alcohol and Drug Recovery Service. So our challenge really is to get people into treatment services as quickly as possible. We've been working very closely with the ADP. The ADP have got a new development programme, and we're looking at a new plan for the ADP in the near future, because I think that it's far more than the wider, it's far wider than Alcohol and Drug Recovery Service. It's about the wider community, recovery community, and the people of Inverclyde to support people getting into the right treatment at the right time. So that's a real challenge for us, is to get people into treatment timely. Where we actually measure well is when people do present to the service, they get access to care and treatment very quickly, and the evidence suggests that, but it's about keeping people in treatment. We're obviously increasing the use of residential rehab, and we've done that fairly recently. You know, we've got work with Turning Point to make sure that we get that pathway into rehab right. So there's lots of things going on, but ultimately it's about working with our colleagues across, you know, police, justice, all the other services and agencies to make sure that where we identify people have a drug or alcohol issue, that we get them into treatment as soon as possible. So that's part of our ongoing work, and obviously getting Matt into primary care. We have shared care clinics, but we want to increase that capacity there. So lots going on to try and support people get into care and treatment. Thank you.
Thanks, Gail. I'll maybe give Kate the opportunity for a final word here, and I'll come back to Becky. Kate.
Just two things. So the prevalence of our care experience young people through the through care system about particularly alcohol and drugs, and particularly drugs, is significant, Becky. So you were right to ask the question. And I do actually think that we have to have a sharper focus on how we support these young people in terms of more bespoke interventions that allow them to integrate into the services that Gail has described that are developing, but coming from a position of understanding their story too, because I think sometimes, as you well know, even in your own professional career, the story of care experience young people are not well understood when they start engaging in services. And just to offer a point of reassurance, I had the privilege between Christmas or before Christmas to spend a couple of hours with our through care young people that came back for a Christmas dinner, and in many respects it's probably the only Christmas dinner that they would have had at that time of year. So you have to appreciate that, you know, the impact for our care experience, and particularly our older care experience, is significant. And they travelled as far as Easterhouse to come to that to make that connection back into that team. And the relationships are second to none. I suppose that Jonathan's challenge and opportunity is to build on what we know is working well through the redesign process, and that's a bit that we want to strengthen. So I was both taken aback that the importance of the relationships between social workers, support workers were fundamental and making a difference. And the more that we develop these relationships with that cohort group of very traumatised young people, the more likely we're going to reduce any possibilities of fatalities moving forward. Can't exclude it completely, but the relationship's so important. So just to provide you a wee bit of insurance around that.
Thanks, Kate. I'm confident that Becky takes assurance from all those responses. Let me draw stumps. Thank you, Jonathan. A really healthy and strong discussion around the Chief Social Work activity. Thank you for bringing a few slides. I think when you've got that sort of level of the report, it's always helpful to get that tighter context about what you believe we should think about. So that was helpful. And I think a really valuable discussion. Some points for assurance, others really for general interest or information. So a really helpful discussion on the Chief Social Work Officer's report. I think we note it's been to the Council, and we note that it is prepared now to go on to the Chief Social Work Advisor as part of the routine annual report process. So thank you to you and others for the work you've done there. I'm grateful for that. Let us move on. Before I do that, I'll maybe just remind members, I think we're looking at the captain switching on the passenger seatbelt signs. I'm confident we'll land at 4 o'clock. So unless people do want a break, we would have it now. I think we'll just press on. There are 3 relatively short reports. They might generate discussion, but I don't imagine that they're going to push us over the line at 4 o'clock. So with your agreement, we'll press on to item 7, which looks like a good news story. It's a short update from Alan Best on the care at home inspection. I'm going to go to Alan, then I'll come back to Kate. Alan.
Thank you, Chair. Yes, as you say, I'm really pleased to bring this report to the IJB today. Report provided you with an update on the recent care at home inspection carried out by the Care Inspectorate. This was an unannounced inspection on the 6th of November, which was carried out over 7 working days, which concluded on the 15th of November. The board will be aware there's been a number of papers over the last year in terms of our care and support at home service and our colleagues that work in it in terms of the review of the service and focus around recruitment and retention. It's a very, as you know, it's one of our largest services within the HSEP with over 500 colleagues. I'm really pleased to say that the inspection report that we got back from the Care Inspectorate was extremely good. If I take your attention to 1.4 in the paper in terms of how well did we do supporting people's well-being, that was rated at a 5, very good. People's experience, compassion, dignity and respect, 5, very good. People get the most out of life, 5, very good. People's health and well-being benefits from their care and support, again 5, very good. And how good is our leadership within the HSEP at care and support at home, and that was 5, very good. And their quality assurance and improvement is led well, 5, very good. As with any report, there's always learning, and we recognise that there's still learning and development in terms of the administration of medication, and the team has taken that forward with colleagues alongside our pharmacy colleagues and our nursing colleagues. The administration of medicine is developing an ongoing changing position in care and support at home, so that's an area that we continue to develop. The recommendation is to note the outcome of a successful inspection. I would say in benchmarking across nationally, 5, very good comes out at the very well end of the spectrum when we compare against other areas. So I would just like to say again, this really does, the credit goes to all the team in care and support at home across all the colleagues that are out there throughout the day and night supporting our community to get that level of inspection report in probably one of our peak periods of the year is nothing short of phenomenal. So it was just pass that on to the board to note. Thank you very much. Happy to take any questions.
Thanks, Alan. I'm open for questions. David Gould and then Christina Boyd.
Thank you, Chair. Just a very simple one. Obviously, this is fantastic news, Alan. That really reflects all the hard work that's gone into this. So that's a real feather in our cap. I'm wondering how we actually communicate this to everyone in our team, because when we have a good news story like this, it's how do we actually get that out so everyone knows and can reflect on that on a job well done.
Yeah. Thank you for yourself, Chair. Yes, thank you for that comment. And yes, this is something that as a service we certainly want to make sure this is passed through all our colleagues across the service and the wider, in terms of the families and carers that are linked in with the service. They already know about the quality of service, but to hear that fed back as well, I think that gives reassurance to our community that we have a service, but we're still learning, we're still developing, but it gives that level of reassurance across all our service users, families, carers and partners.
Thanks, Alan. Thank you, Chair.
Christina.
My family currently use this service, and I have to say we are extremely happy with it. We have an elderly lady, almost 90. We have 2 carers in 3 times a day. They're competent, they're kind, they're well trained, they're willing to go that extra mile. They turn up, which is not something you can always say whenever you've got some of the private sector. We recently had a crisis when the carers were in. The family member who was looking after the elderly lady collapsed in a heap with her heart. One of the carers stayed with her until someone could get there, and the other one went on to do the other job, and somebody else was allocated to the other job. We were very, very impressed. You thought I was going to complain there, didn't you?
Christina, thanks for that real life example feedback. We sometimes get a lot of real life feedback, which is on the other side of the curve. So it's great to get a real life practical experience of somebody who's using the service now and I guess aligns and acknowledges with the report that we got that it's performing particularly well. So thank you to Alan. If there are no other questions, and I'm not seeing any, Alan, thank you for bringing the report. It is always nice to get a light, so not too lengthy, but a really strong endorsement of local services. It's clearly a high-performing part of the workforce. I think the board would just want to, as David Gould has said, place on record, I guess, our thanks, gratitude for the work that's been done in this area, supporting Christina's comments and recognising that good work has been done. Of course, we'd want that to continue to the best standard possible in future. So well done to the Care at Home service and the folks that are associated or work with that service. That nicely brings us along to the last 2 items. The next one is the Chief Officer's report. There are 4 or 5 items there. I'll just ask Kate maybe to talk briefly to each of those, and then we'll open it for questions. Kate.
Thank you, Chair. So I'm just going to take you through them very quickly. They're very straightforward items. They're really for information. But I suppose the first one is call before you can convey, which is our pilot for care homes. And if we think about the previous discussion that we had around the cancer journey, this is about some of the improvements that we are making in Inverclyde to join the services up. So, for example, we have recognised that the relationships between Gowan and ourselves are really, really strong, and we need to capitalise on how do we do that together, given the many challenges we have about recruitment and retention, and ensuring that within this area of work, which takes great skill and sensitivity, that we use, we kind of bring our expertise together. So I would thank Laura Moore and Alan Best for the efforts of taking this forward. Now, obviously, we are doing a test to change about what that can look like. And we believe that we probably have a story to tell around our unscheduled care, and which is care group, or what our future planning or unscheduled or our plans look like, where that we're not anticipating them, for want of a better word. And you know, dying well is really important, and palliative care is really important in that journey. Recognising that for many of our community and people even on this call that want to die at home is their kind of optimum aspiration. So we'd be keen to bring back some of the learning. I'm conscious that March it would not be an appropriate timescale, so perhaps maybe that would be for some of our highlights if Laura, I don't want to kind of hijack Laura to kind of provide some of our high level outcomes from that call before you convey pilot. I think that would probably be reasonable for us. The next thing is just a lens project. It's just an update about the previous one, just to give you a sense of some of the innovation that our frontline staff came up with. And I think it's really important because these bits of innovation that have been identified will be kind of put into a promise plan in terms of our local delivery. So this is a real opportunity to kind of see change coming from our practitioners that are actually sustainable and proportionate, and none of these actions were disproportionate in terms of the ask, in terms of finances, and the chair and the vice chair were part of that process, and I think they were really taken with the level of energy, motivation and skill that the workforce had. We're also going to be doing it within adult services, and Alan's Best is working through that plan, and we would hope to report back some of the innovation that our front door, our frontline services are identifying. We're hoping at some stage that this approach, innovative approach, would replace our transformation board with an added footprint around an energy from our workforce. The next thing is just to give you an update where we are in the joint inspection of adult services. The fieldwork phase starts, I actually think, probably this week, if I can recall, and that we've had to kind of, there'll be 54 files that will be uploaded as in tomorrow for the care inspection. Now, the level of activity as well as the position statement has been hugely challenging for us as a management team across the board, particularly around it being an inspection over 7 months. So its footprint is significant, and the final report isn't expected in late March. The final report, that's a typo actually. The final report is, we're unclear, but we will get feedback by May. Okay, so if I can just make that as a typo, I think it was March, it must have been, my writing has kind of misled everyone. And the homeless redesign, well, we've already had that discussion. And delayed discharges, we've had some success in our kind of a robust review of our processes, and we've seen our performance improve, but we're still not out the bit because we're still not out the winter, and that changes on a day-to-day basis. We're still sitting in the top quartile nationally for our performance around delays, discharges. And then the independent review of respite, well, we've kind of covered that, but what we're hoping is that we get the report and the strategy. We'll come back to the scrutiny panel and the IJB in early summer. And I think the importance of this independent review of respite, which will look at the carers provision within it too, in light of some of the discussions that we've had with carers, is that it will be independent from ourselves. So it should scope out what our provision should look like and what our provision will be that will be future proofed in terms of what the people of Inverclyde want. So I haven't got any other questions over. If anyone's got any other questions, please ask me, I should say. So it's still in the code.
Thanks, Kate. So really helpful to get those brief updates on those six issues. I'm going to just look to see if there are any members' comments or questions. I'm not seeing any hands, but I'll just talk as we go along. Let me say a couple of things. Really helpful. Thank you. As Kate said, she invited Robert and I to be both on the panel for the lens. So my personal perspective was it was a really empowering day. It was great to see different parts of our staff come together with new ideas around transformation, with a sense that we were looking to empower them and that we had resources to help them deliver their pilots or their change programs. So I think it's entirely consistent with thinking that, as Kate says, if that looks like a process that can be brought together to go forward, that we might use broadly our transformation program to back that up in the future. I know that we'll get further reports from Kate as these programs mature. I think we funded 4 out of 6 and we supported the other 2 in different ways. So just a really refreshing approach to empowering our staff and listening to their ideas and questioning them and then supporting them. So I thought that was fantastic. I'm looking at the other stuff on the list. I guess the one that kind of always stands out is the delayed discharge. Kate summarised that, and I think it's right that on each of the occasions we just take a quick check to see where we are, both locally, what the pressure is on our resources to be able to deliver that, and of course how we might sit in the pack. Some people like to know whether the top, middle or bottom and what the problem is. So thanks for bringing that regular update on delayed discharge. So with that, I'm not seeing any hands, so I'm happy to say, Kate, thank you. I'm happy to note those items in that report. And that really brings us to the conclusion of the open part of the meeting. As I normally do, I will just pause